Health.
Okay.
Oh, recording started there. Nice. Very nice. So nice to see everybody. And Kathy, thanks so much for the invitation to come out here. And I know Stephanie Whitwer as well, who I think may have made the initial connection. So thanks, Stephanie, for that also. And really appreciate an opportunity to talk about the program and about healthcare homes and answer any questions if indeed there are any. My background, I've been with the department for about a decade, a little over a decade. I've been director of the program for a couple of years, but was part of the program for my entire stint at MDH. I worked at a hospital. I worked in a clinic. I've worked in nonprofits around healthcare. I've been in health or public health for 25 plus years in one way or another, but definitely the last 10 have been here at the department with healthcare homes. And I have a fabulous team. It's a great job. I love what I do. And so I'm always excited to talk about it and help hopefully make people more acquainted with our work and what we're all about. So pardon me if my technological savvy does not work here, but okay. I'm going to send, so I guess I'm sending you, Kathy, a sharing request.
Okay.
And then you can let me know if there we go. All right. One sec. Can folks see my screen?
Yes.
Great. All right. Oops. Let's go back one. Yep. So anyway, once again, I represent and director of the Healthcare Homes program. And real quick, what Healthcare Homes is not, because this is a misconception that shows up a lot. We have nothing to do with home health. We have nothing to do with long-term care or anything to do with those kinds of areas of healthcare. Due to our name, we are often mistaken for that. I receive quite a number of resumes every year from folks who work in long-term care who are looking for positions and believe our program is affiliated with that or with home health. Field a lot of calls. Just has to do with the name. It's really supposed to be healthcare home, like it's like the home for your health, like the hub where your healthcare is all focused. In that sense, that was kind of the idea when they created the program, which I will proceed to talk about here. But anyway, unfortunately, or fortunately, however you want to look at it, the name has created some confusion. And while we've talked about changing it, the fact of the matter is it would require an act of the legislature to change the name. So that's probably just not worth the effort that it would take to get that to happen. And so we have come up with like a tagline and stuff to clarify what we're all about. But basically, healthcare homes it's a care delivery approach or model. That in which primary care providers, patients, families, and community partners work together to improve these sort of triple aim goals: the health outcomes, patient experience, and also value of care in the sense, lowering costs while still maintaining the same level of quality where possible. So that sort of cost efficiency, talk about sometimes, again, value of care. So again, healthcare homes is a primary care model. It was developed, or I should say at least implemented originally as part of the 2008 health reform legislation here in Minnesota. And the first clinics were certified in 2010. It's actually unclear who wins the prize for first clinic. It was two Lakewood Health System in Staples, and then Dr. Christopher Wenner, who was a solo practitioner in Cold Springs, both certified pretty much almost simultaneously. So they can both hypothetically claim the title. Healthcare home is Minnesota's version of what you might have heard of a patient-centered medical home model. That's, again, a model of patient-centered care that's been around for some time. Almost every state, if not every state, has its own version of this. So in Minnesota, it's called healthcare homes. Oregon has another version. Arkansas has got their approach. Texas has their version of medical home. It seems to exist in one form or another. There's also a national organization called NCQA, which offers certifications that cross state lines. That's an organization, again, some folks may be familiar with. They work in this area as well. Sometimes this is healthcare homes is called an advanced primary care model. Also, that's sort of some verbiage that's come a little more in vogue recently, talking again about primary care approaches that go beyond the sort of basic or minimum. I would stress that healthcare homes really is patient-centered and team-based. The focus is really about moving the patient to the center and the family to the center of care decision-making and getting away from what is sort of a more, I guess, traditional sort of top-down model where the doctor kind of would issue orders and the patient is sort of expected to do what they're told, and in a weird way is almost not fully in the driver's seat when it comes to care. This is, again, much more encouraging this team-based model in which nurses and clinicians and if it's necessary social workers or other folks are all part of a care team that works collaboratively together to enhance patient care and enhance the experience of the patient while still leaving the patient themselves educated and empowered to make choices about their own healthcare. So that's kind of what the model is shooting for. Ultimately, it builds definitely on a foundation of primary care that again is at the heart of this model, is really that focus on primary care. Again, I mentioned increasing care coordination and collaboration. Care coordination, I'll talk more about it, but it's a huge part of the model, and really getting folks out of their silos and building new communication pathways between different types of providers, both health and community-based, and trying to, again, build a sort of an almost a medical neighborhood, you might call it, where, again, patients are receiving the most high quality and most efficient form of care. There's also a big focus on improving population health, on advancing health equity. Obviously, you've probably heard the news that health disparities in Minnesota are very, very extreme. We have excellent healthcare in the state, and overall, we rank quite well when it comes to a lot of metrics that track the health of populations. But disparity-wise, I don't know exactly where we're at. A few years ago, we were 49th out of 50 in terms of how bad we were, like in terms of how the level of disparities. I think only Mississippi had worse health disparities than Minnesota. I think the other 47 states or 48 states were doing a better job with that. We may have moved up the rankings since then. That was just a couple of years ago. But when you're the second worst in the country, that definitely is saying something about the level to which this is an issue, affecting a lot of different types of populations. So definitely Healthcare Homes is looking to reduce these kinds of disparities and balance out inequities. And we're also focused on the quadruple aim, really adding in that aspect of staff satisfaction, of practitioner and clinician and other folks who are involved in care, also enjoying their work, hopefully avoiding burnout when possible. And in general, we're kind of committed to trying to help them improve the quality of their experience in the healthcare profession. So that's something, again, that's sometimes discussed as part of the quadruple aim, and something we definitely tend to shoot for. Let's move this over here a second. Again, research into healthcare homes and other like models has shown a lot of very positive effects. We had a state legislatively sponsored study that was done in 2014. It was a 5-year evaluation. Obviously, I understand that data is pretty old, but nonetheless, it did show improvements in terms of healthcare homes versus non-healthcare homes certified clinics. They found improved or enhanced levels of quality with regards to diabetes, asthma, depression, and colorectal cancer screening. Patient experience levels were higher. Patients reported greater satisfaction at healthcare home certified clinics. There were a lot of cost efficiencies, I should say, that were essentially identified via different metrics. For instance, healthcare home clinics had lower rates of ED utilization, unnecessary, I should say, ED utilization, lower rates of inpatient or unnecessary inpatient hospital stays. And when patients were hospitalized, they were hospitalized for fewer days. They calculated about $1 billion in savings to the healthcare system overall. That's spread out amongst different entities, of course, but it was a pretty good number. And they also found staff satisfaction was higher too, and that practitioners at healthcare home certified clinics tended to be happier in their work. There have been subsequent research. In 2018, there was a paper released on diabetes that again found that healthcare home certified clinics were doing better with diabetes care. There have been other studies around the country. I think 30 in total were put together in a meta-study around the patient-centered medical home model. Again, this model that healthcare homes is a part of, and again found like similar kinds of outcomes when they looked at clinics in different, or rather I should say, implementations of this model in different states and how clinics were performing. So at the end, I have a slide that's got a bunch of references as well to the various studies and things. More recently, healthcare homes is part of a big study with the Health Partners Institute around really care coordination. And again, really just finding that care coordination makes a huge difference in terms of care and quality of care. And that, again, is a major part of the healthcare homes model. So just wanted to cite that. This is kind of a by-the-numbers snapshot. Something like 59% of Minnesota's primary care clinics have been certified as healthcare homes. So we have 390 clinics certified, spread out among something like 78 different organizations. And you see here there's levels. I'll talk more about the levels later because we have different levels of certification. But about 80 of those clinics are at the foundational or beginning level. 61 are at level 2, and actually the majority at 249 are at level 3, the highest level. Now, I have to qualify these numbers because the healthcare landscape, as you know, is just constantly shifting. I'm getting a denominator, that percentage there, the 59%. I say roughly because there's no master list of primary care clinics in Minnesota anywhere. Unlike, say, hospitals, there's no official accreditation where there's a state or national registry you can go to and count the numbers. Healthcare clinic or primary care clinics pop up and disappear all the time, especially since COVID. 2020 was a rough year. We saw 30 healthcare home certified clinics close their doors. And in the last 6 years, certainly we've seen lots of closures. We've seen openings as well. We keep one of the best and most comprehensive lists in the state of primary care clinics. We're pulling them together from lots of different resources, but I have nurses who work with me who will be driving along and all of a sudden see a billboard for a new clinic. And the next day they'll come on in and say, guess what? There's a new one that opened in Crystal, and here we go. They're called this and this and this, and we'll add them to the denominator. So again, the numbers tend to shift around a lot. So when we're talking about certification for healthcare homes, and again, our program at MDH certifies clinics and organizations to be healthcare homes. We certify them as having fidelity to this model of care and implementing it with fidelity and successfully. Eligible clinics take responsibility for patient care. They provide a full range of primary care services. So to be certified as a healthcare home, you have to provide what we call full spectrum primary care. So for instance, if you're a Minute clinic, you wouldn't qualify, or a lot of occupational health clinics that maybe just deal with wound care or more specialized kinds of limited offerings in terms of their services are not going to qualify. You have to really do the full spectrum. You've got to offer immunizations. You've got to do preventative services. You have to manage chronic conditions. You have to be able to offer that level of care. Generally, an individual clinician or primary care clinic can be certified. I say individual clinician because, in a sense, when a clinic is certified, all of the clinicians, whether they're nurse practitioners or PAs or MDs or DOs or whatever, they're all essentially certified. And so in theory, if you're a single solo practitioner, I mentioned a Dr. Christopher Wenner, who's a solo practitioner, for instance, you can be certified as a healthcare home just as an individual clinician who's operating your own practice, doing your own thing. And maintaining status as healthcare home certified, you have to renew every 3 years. It used to be every year, and that was just crazy making for everyone. For the clinics, it was crazy for my staff. We were all running around pretty much nuts. So thankfully, the legislature responded to a request and shifted the certification to an every 3 years cycle. And so essentially, we have nurses who work with the clinics directly, and every 3 years, clinics fill out a sort of a recertification application, and then they gather a team and they meet with our nurse planners and discuss, what they've been up to and get to share their successes and talk about what they're doing with regards to the model. And then, assuming that all has gone well, they're then recertified for another 3 years. I should say also the healthcare homes program is voluntary. This is not a model where we're trying to force you to be healthcare home certified or something. If you want to be certified and you meet the standards, you can become certified. But you are under no duress to remain certified. And if you want to stop, you can stop. There's nothing, this is not a regulatory program in any way, shape, or form. It never has been. And I see no reason why it ever would be. Just to share kind of our 5 standards that underpin the program and make it really what it is. And I have some examples. There's a number of requirements that you have to meet for each of these standards. And we have lots of guides and manuals and things that show what they are. But the general idea is standard 1 is access and communication. And I provide an example here. You got to provide 24/7 access 365 days of the year. And I don't mean that you have to be open 24/7, 365, just that you have to have some means that patients can connect with you. Maybe it's a nurse line, maybe it's a phone triage system, some way that after hours there can be connection to providers if a patient needs to get in touch with them. We also require that clinics identify complex patients, needing to identify those who require a higher level of care and who may have one or more chronic conditions that need management. How the clinics do that is up to them, and that's something else I would stress about the model. Healthcare homes is super flexible. You have to meet the standards, but how you meet them is up to you. And there's a lot of different ways you can do it. So everybody who identifies complex patients, some folks do it with a risk algorithm that scores patients, and if they meet a certain score or threshold, you identify them as complex. Other folks take out a bunch of pieces of paper with patient names written on them and sit down and read them through, and then they have their own kind of system and they stack them together and they say these folks qualify as what I'll call complex patients. There's lots of ways, and I'm not kidding about the paper. I know of at least one clinic that is completely paper records. They will not use EMR or any form of electronic records. They stick totally to paper. So that does happen. So there's quite a range of capacities and sophistication and what folks are doing when it comes to how they're doing healthcare and how they're implementing this model. The second standard is patient registries and tracking. So you've got to use patient registries to track care activity and identify, gaps in care. Again, how you do it is up to you. A lot of folks are using EHRs and have a variety of different, they'll have their asthma registry and they can pull it up and look at patients. But again, other folks are using Excel spreadsheets. I mean, it really is dependent on how you want to do it. But we do require that you track that activity, that you identify gaps in care using patient registries. Standard 3 is care coordination. Again, this is I feel a really important standard to stress just because this care coordination practice is so central to what we want folks to be doing within healthcare homes and in healthcare more generally. You have a designated care coordinator, at least one, and many practices have multiple care coordinators. And I would say that maybe relevant to this audience, I mean, I would say a large chunk of care coordinators are RNs. They often occupy this role in organizations. Not 100%. There's some instances where social workers, that's another common professional role that is sometimes assigned as care coordinator. There are those who use community health workers and et cetera, but RNs make up a very significant number of folks who are working in this area. At the very least, you've got to be coordinating in some way with external providers and facilitating communication between a primary care provider and specialists, other folks. But ideally, it's going even beyond that to connect with behavioral health and with other, let's say they have a social services coordinator with the county, connecting with those folks. And the idea, again, is building this robust care team and keeping information flowing. And in some cases, obviously the folks are doing a great job with that one way or the other, but there are also instances where that communication is very poor, especially when a specialist might be with one system and the primary care clinician is working in another area, and then the behavioral health folks work for a nonprofit. And before you know it, information is not getting back and forth, and folks don't know what's going on, and they're replicating care, they're confusing patients, and it's leading to just a real mess. So care coordination is definitely something that both enhances quality of care and also boosts patient experience. And that's really something research has shown a lot about. Standard 4 care planning or care plans is kind of a smaller standard. And this is just where necessary. It asks that you develop plans for patients that involve managing chronic illness and that include patient-centered goals. I mean, again, back to that notion of centering patients in care and making sure that patient-centered goals around management of chronic illness are being highlighted in these care plans. Obviously, you're not going to have a care plan for your whole patient population. It's going to be just those folks whose complexity requires that this kind of a plan be developed and implemented. The last standard here is performance reporting and quality improvement. Healthcare homes have to establish QI teams that meet and work on quality improvement projects within the clinic. You're required to submit data, but that is actually really just us replicating a statewide requirement. Technically, all primary care clinics in Minnesota are required to submit certain metrics to the state quality reporting and measurement system, SQUIRMS, on an annual basis. And that data is collated and compiled and then made available. The vast majority do that, honestly. Some do not. Some have refused or requested variances for one reason or another, but the great majority do submit data. So our data submission requirement is really just kind of an echo of that. We've actually tried to move away from benchmarking clinics purely on the basis of submitted data. Sometimes those metrics that are required don't necessarily showcase what they're doing best. And there can be a lot of arguments about why it can be duplicative for them to be submitting data to the state when they're already doing it for 3 other things. I know measurement burden's a real problem. So we've tried to actually emphasize asking clinics to share with us some of the metrics they think are important around what they're doing and to really try to talk about how year to year they're working on their own goals within measurement and sort of benchmarking against themselves, basically. So we still use data about, comparing to state averages and all that, but we really try to get away from making that the sort of center of this process. We're much more focused on what the clinics are doing, what they think is important. Because again, what one clinic is doing with their patient population, what they see as valuable might just be radically different than what another clinic 100 miles west is doing. They just may have a very different patient mix, and they may be looking at very different kinds of things within data. So we also require participation in learning collaboratives. Healthcare Homes does a ton with learning, and you're required to do something with learning. I'll talk more about learning in a little bit, but we do a ton of that. It's a major part of the program, and we do ask folks to participate in that as well. So there's a number of different incentives and reimbursements and benefits to being healthcare home certified. I mean, obviously, we hope folks are going to do it because they want to do it and because it enhances the quality of care. But obviously, you're also going to look for incentives and benefits. One thing you can do is bill for care coordination services for your Medicaid population. That's something that the Department of Human Services will reimburse you for care coordination of Medicaid patients, depending on their complexity and a few other factors. There's a tiering system and a billing process. A lot of commercial payers have mimicked that process. And so depending on your contracts, Blue Cross Blue Shield or Health Partners or Medica or some of these other companies will also pay care coordination rates, as it were, per member per month, generally speaking, although of course it can vary by provider. But for Medicaid populations, that's the main one that is usually being billed in this way, but again, not exclusively. Healthcare Homes also prepares you for participation in value-based programs and alternative payment arrangements by, again, increasing your capacity in a number of ways. An example is, I don't know if you're familiar with the Minnesota Integrated Health Partnership, or IHP. It's the Medicaid Accountable Care Organization for the state that brings together clinics, and it shares, certain population-based payments it makes to folks. They can do shared risk and shared savings and different things like that. So participation in IHP, you're required to be certified as a healthcare home, or at least to demonstrate that you can do everything a healthcare home can do. So they use our standards as a sort of a passport into their program. And in a number of cases, there are other programs, again, maybe that aren't as formal, but other value-based arrangements where, again, being certified is an advantage in terms of performing well, and thus, in theory, getting better reimbursements and better financial support. We also are recognized by CMS, part of their merit-based incentive payment system, or MIPS. If you're healthcare home certified, your Medicare population, you get full credit for this improvement activities category, but essentially it helps facilitate you're getting better payments from Medicare for patients who participate in this MIPS payment program. So again, there's a way for your Medicare patients to get reimbursement for those services that you're providing to them through healthcare homes. There's also some sort of more intangible things like access to learning, of course. And then there's benefits to board certification for family practice physicians and pediatricians. They get a boost on their licensures, their relicensures, or relicensing process through the national academies. They recognize healthcare homes as a model that essentially allows providers to skip a number of steps in their relicensure. So that can be a benefit for some clinicians as well, that I know is popular, and they love to save time on that and paperwork and some of the other obstacles. So I mentioned earlier that there's these different levels of certification. This is a somewhat recent thing. 2021 is really when we debuted these different certification levels, and we really did it in response to local and national trends where there was really a push to have primary care begin to expand above and beyond what it was just doing within the four walls of the clinic, and to get involved with other aspects of health. Obviously, social determinants of health, or social drivers of health, or health-related social needs, however you want to, whatever nomenclature you want to use. I think most folks are familiar with the notion that that's driving like 80% of health outcomes. And there's been, of course, a huge focus in healthcare on how the healthcare system can work to address those. And this is our attempt to kind of support that. So when you're first certified, you're foundational, which has that focus on team-based, patient-centered care. But you can progress to level 2. And in fact, you can be initially certified at level 2 if you can demonstrate that you meet the standards. And these include added screening for and addressing social health needs, and having official screening processes, as well as having some sort of follow-up system or mechanism by which you deal with the screening results. I've heard a lot of folks say, we screen and then we do nothing with the screening. We just note that there are these so-and-so has food insecurity, and then we make a note of it. But I've had a lot of clinicians and nurses and other folks say, we don't know really what to do with them at that point. We've got this information, but to be level 2, you really have to have some sort of mechanism in place. And we work with you, if necessary, to help you figure out how to do that. We require enhanced access to care, better integration of care teams, mentioned better or more enhanced work to address health disparities and advance equity. And we focus with level 2 on strengthening community partnerships and trying to build more partners within the community that, again, a patient's care can be enhanced. And then level 3 is really about population health. It takes it to a next level. You have to be contributing to and participating in community health needs assessments and population health improvement planning. And it involves sharing responsibility and implementing and monitoring the progress of those efforts. So whether that's working with local public health in their assessments, or working with hospital systems when they're doing their community health needs assessments, it involves sort of an expanded use of data and more of an emphasis on whole populations that go beyond merely your clinic population, but involves strengthening your community as a whole, with the notion that a stronger and healthier community is naturally going to benefit your patients as well, even if those benefits are then spread in a wider sense, or you're casting a wider net. So again, that level 3 is really about moving to this very much community-based model of health and population-based model of health. So our learning collaborative or healthcare homes learning is a really big thing for the program. We always say that like the program's got two pillars or two foundations. One is that certification, recertification process that's so integral to healthcare homes. But in addition, learning is considered to be a major aspect of the program. And we do this in a lot of different ways. Certainly we do it through technical assistance. I mean, when you're certified, we have a nurse who is essentially assigned as your practice improvement specialist, and that person becomes your point of contact with us, and they'll work hard to help you with not just with your healthcare home related needs, but really with anything that you would like MDH to assist with. Not that they can make anything happen. I want to back up and caution that that would be outside of my authority, but they definitely work to try to make what connections they can make. I mean, to get you the services or the data or the information that you need. They're there essentially on call to try to work with you. And so that's a form of learning too. I mean, there's an example of a clinic I know up in Red Lake that was having a tough time with asthma care, and they contacted their practice improvement specialist. That person contacted the MDH asthma program, got several people from the asthma program together. They all got in a car and drove out to the clinic together and met with them and started working with them to help strengthen their asthma care program. So there's that kind of technical assistance-based learning. But we also have lots and lots of opportunities for certified providers of care, members of health teams. We've got over 30 e-learning modules covering everything from telehealth to behavioral health integration, care coordination, diabetes management. There's a lot of different topics. We do monthly webinars, which are available to anybody to come and listen in on one of our webinars, but the recordings are only available to the certified organizations. Our topics, I should say, for things like e-learning and webinars also, we don't just kind of come up with them and then just decide one day, well, we'll just do this. This sounds good. We really go out and talk to clinics and talk to healthcare workers and try to find out what people need and want and what they're interested in. And then we try to respond in that way with webinars, with e-learning, with in-person trainings as well. We did several health coaching trainings. We got a health coaching expert at the request of some clinics, and then started and held 2 trainings on health coaching, and they seem to have been extremely successful. We recently heard back from one of the organizations that it really revamped how they do patient engagement and changed what they do. So again, those are of course free of charge. We set that up and then make sure that the trainers are in place and the education's in place. All of this is free of charge. We don't ever charge for anything with healthcare homes. The one exception being our annual conference. We do charge a fee for that, and that's open to anybody. It's a super low fee to be fair for a conference, but that's the one area we do have to charge. Peer-to-peer networking is also a huge thing. We were for several years were involved with this, and then due to our capacity being reduced, we had to let it go. We're going to be bringing it back in 2027, really trying to. This is just in response to a huge request from so many different organizations that they really want to talk to their peers. Clinics want to know what other clinics are doing about patient care and patient engagement and every aspect of what's going on, burnout, and how they're dealing with financial issues. And in many cases, organizations want to hear from other organizations that are similar to them, maybe in patient mix or in size or in some cases location. So we're really looking at different models to bring together clinics from around the state and find ways to help them engage with each other. And we'll create the platform and facilitate maybe having case studies or other things that are brought forward by individual organizations, and then really breaking things up into maybe groups of like clinics that want to talk to each other about these, either what was just presented or they can range off into other discussions as well. Anyway, I'm just kind of previewing these plans. It's still a work in progress, but again, our aim is for in 2027 to get that going and really try to facilitate, again, more sharing, because there's so many good ideas out there that are going on that folks are doing and so many incredible things you hear about, but they're not necessarily being shared because there just isn't always a good platform to share those things outside of maybe an annual conference or that kind of a thing. Well, they have a newsletter, but if you're not subscribing to the newsletter, you never hear about that work they did in screening or something like that was so revolutionary. Just a word too about our partnerships and collaboration, of which we do a ton. Obviously, our clinics are our main collaborators. That includes the staff, but we've also been trying to really work on connecting with patients a lot more directly. Our primary, stakeholders, I guess, are clinics and healthcare staff, but we really do want to hear from patients. So lately, we've been getting invited to patient family advisory councils and getting a chance to talk directly to patients. We've created a patient-facing webpage that is really, our website is mostly aimed at healthcare folks, but we have created a patient-facing webpage, and we're really working to try to find ways to engage patients and help patients be aware of what a healthcare home certified clinic is and whether that would be a good choice for them in terms of their care. We have an advisory committee, which is a very heterogeneous group made up of folks from all over the spectrum in terms of healthcare, and also includes patient representatives. We have a sustainability work group that works on issues of financial sustainability and how to sustain both your primary care clinic in general and your healthcare homes implementation particularly. We have partnerships with a lot of database organizations. And then, of course, the Department of Human Services is a big partner of ours, too. They administer that Medicaid payment part of the program. And we're just very active in working with them on a lot of different things, trying to engage them, since what they do often touches so much on our work as well. So we certainly are always interested, however, in broadening these collaborations and finding new partners. That's something that I think we do a good job with, and something we're really, really committed to. And I feel we can't get our work done without it, quite frankly. Along those lines, just to share, if you're not aware, there is this primary care stakeholder group. I'm happy to say Healthcare Homes founded this along with the Minnesota Academy of Family Physicians. We partnered to develop this this group that now I think we have like maybe 40 members or something like that. I'm not sure. They come from all over healthcare. There's insurers, there's clinics, there's hospitals, there's professional organizations, there's nonprofits and consultants and data experts and folks who are just doing all kinds of things, but they're all united by an interest in making primary care stronger. And this is something that really Healthcare Homes has been very, very much involved in recent years. It's going beyond just our own personal model, but really working to sort of champion primary care in general and try to find ways to strengthen the primary care system. I mean, as folks are aware, we're seeing a real drain in primary care. We're seeing fewer and fewer folks going into primary care. We're seeing clinics getting overloaded in terms of patient loads. We're seeing providers move into other areas. The call of specialty care is out there, and no disrespect to specialty care, but it pays more, and in many cases, folks are going to go that direction rather than into primary care. And certainly, the way medical schools are structured, you're incentivized to go into specialty care in a sense. Some of the folks who score the highest usually are picking specialty type, not always, but are often taking specialty residencies and that kind of a thing, and not going into primary care in particular. And this is not just a Minnesota issue, it's a national issue. So we are seeing sort of a brain drain when it comes to primary care. We're seeing a wave of retirements and not enough folks to replace them. And we're also seeing underinvestment in primary care in general. As again, I'm sure you're familiar, primary care just does not get a big slice of the pie when it comes to healthcare spending, nationally or locally, but it drives a huge number of outcomes. And a much larger share of health outcomes are driven by primary care, and it's not commensurate with the funding that primary care receives, which is again a concern to folks like us who really want to see a robust and strong primary care system. So this coalition, the stakeholder group, is working on a lot of different fronts to try to find ways, whether it's through policy levers or through a local organization and action, to strengthen primary care in Minnesota, and to find ways to reduce burnout, to draw people into the profession, and to spur investment as well, really, from government and other folks in building a better primary care system. So for Healthcare Homes, just a huge deal. So thanks. That's kind of raced through that, and I apologize. I have a tendency to talk fast, and so I do have to say that is one of my things. I have to really remind myself to just slow it down a little bit sometimes. So if that was a mad race, again, I do apologize. You can connect with us through our Learn Bulletin, through subscribing to our newsletter. That's my contact information. It sounds like, Kathy, you gave the slides to folks, or you'll distribute the slides to people if they're interested.
I will, yeah.
Okay, thank you. Yeah, so obviously anybody can get in touch with us if they want to and have any questions. So yeah, that's, I'll stop sharing there and that disappears so I can see everybody's faces again. So thanks, everybody. Yeah, I don't know if anybody has any questions or anything I could answer, but I'd be happy to if there are any.
Oh, yes. This is Rachel. Can you hear me okay?
I can, yeah.
Okay, perfect. Sorry, I'm eating, so I had my video off.
I get it.
But I loved your presentation. And I was actually emailing Kathy about it because I'm actually finishing up my dissertation next month, interviewing foster families. And I actually started this work 6 years ago, and I actually presented it in a national conference about a medical home model in foster care. And like proposing like how could this work, and I have kind of pivoted a little bit to just move more into like just focusing on the care coordination model. But like it's just so hard because like yes, I see like how the whole medical home could work because it is the primary care, but then like primary care has a harder time integrating into the foster care system. Like, have you had any experience, or has there been any conversations? Because I definitely would like to connect with you, because what I'm trying to do right now is build a case that in foster care this kind of model is needed to help decrease disparities.
That's fantastic. Oh, sorry. Go ahead. I'm sorry. I didn't mean to cut you off. If you're
No, that was it.
oh, yeah, no, it's fantastic. Please reach out to me. I mean, yeah, we have. I would say, as you know, like you just said it yourself. I mean, primary care in general within the foster care system, there are obstacles and barriers to folks accessing care. I mean, that's just an area where there's some systemic issues. And because of that, I'm not aware of like a healthcare home clinic that specifically works with foster care populations. But I'd love to explore that more and just even just the notion of how can we improve primary care access for folks in the foster care system. I've worked with foster care kids before, and previously in work I did for a nonprofit around health in other healthcare areas, and I know that there were some real issues with services. Let's put it that way, and with getting access to services. So please reach out to me. That'd be fantastic.
Yeah, no, I absolutely would love. Now, just kind of putting you on the spot here, like, because right now, like, I've written a concept analysis on like what I think the components of a required care coordination model would look like in foster care with all of the nuances, but it's kind of, I don't know, what do you see maybe at the current, state of, legislation is because now care coordination was just, in the 6 years ago that I was looking at medical homes, it has evolved quite a bit, especially in Minnesota since then. But do you see it in Minnesota more as taking that angle of the medical home or being like more secular and just like the care coordination?
I think so, yeah.
I guess in your professional opinion, like, do you think I would have a harder time trying to like advocate for like integrating nursing into foster care than implementing like a medical model?
That's a good question. Yeah, I mean, I don't know for sure what the barriers. I mean, if given those two choices, I don't know. I'm wondering if there's a way to unite them, though. I mean, if you could get more nursing care, and then you could have nurses who are care coordinators. I mean, who are really doing that work and building those networks to help folks in foster care stay connected to services. I mean, I would almost see those two things going hand in hand, if possible. I think having that designated care coordinator that patients or clients or whatever words you want to use can go to. That's just a super important aspect of it. They've got to have like a person that they can connect with and have as the hub of those services. And from there you can kind of build that team-based approach. So I don't know if that's exactly answering your question, because it's tough to know exactly, like in this situation, not having that extensive knowledge of the foster care system, it's tough for me to say exactly what would work better, but I could see how you could integrate both of those things in an area like that.
Well, and that's what I was kind of wondering. Because you were talking about Medicare more so than Medicaid, because foster care falls under the Medicaid sector. And, California is, because I make the argument that you can't compare one state's foster system to another because the laws are different and reimbursements are different. But California, they're a very good example of what not to do, but they're also trying to fix it because they've got the biggest problem.
Yeah.
But right now they're trying to actually, kind of like what you did is like a certification, is they're piloting right now a foster care public health nurse. Cool. Or in from the Medicaid sector. So that I don't know if that would get more buy-in, because then I feel like the federal, like you could get more federal monies and state monies from that, because granted the data I have is outdated. They don't run this data very often, but foster children make up the smallest amount of Medicaid beneficiaries, but they have the highest amount of expenditures, especially when it comes to ED utilization. So that's why I'm trying to address some of these gaps, but this is the stuff that keeps me up at night. I just don't know how to go about it.
Yeah, I hear what you're saying, and again, maybe we can, again, if we can connect, I might be able to also help ask around and see if I could also put you in touch with people who are working more directly in this area, who might be able to, again, give you better suggestions than I can. I do know that, I mean, with care coordination, technically, you can, as long as you have an eligible clinician who's somehow involved, you can, regardless of whether you're a healthcare home or not, you can still use those codes to bill for care coordination through Medicaid. It's not the greatest reimbursement ever, but it can be done. So I would just say that you don't absolutely have to have a healthcare home certification to use those codes. That's just, they were created as part of our program, but they are available to other folks. So, and they're very much, again, based on Medicaid reimbursement, even though there are some non-Medicaid folks who get reimbursement as well.
And we have a couple of other people with their hands up. So
Yeah,
Yes,
I can't see.
sorry.
I'm
I
sorry.
will not
Yeah.
to derail everybody else.
No,
All
but it's
connected to
great,
no filter.
Rachel,
Oh,
and
thank you
it's
so
a good
much, Rachel.
resource.
Yeah, I see. Is it Linda?
Yeah, I was just wondering, how or have you done any like measurements of client satisfaction? Because I know that's always, I mean, everybody always, and I taught it in clinical patient-centered care, but it sometimes feels like it's more of a, something we pay lip service to, but people don't necessarily incorporate it. So I'm just wondering how you evaluate if patients are really feeling like they're getting something out of it. Are they really finding that it's useful, or do they get I mean, we may see objective improvements, but I'm not sure if they are seeing it. Because ultimately, with, compliance or adherence or however you want to call it, their satisfaction is really pretty important.
Yeah, absolutely. Yeah, and that's something we put a lot of focus on for sure. And yeah, I mean, the original 5 year evaluation of the program did include metrics that measured patient satisfaction. They really looked at how patients felt about their care, how they felt about their provider, how they felt about their clinic and the team that served them, and those metrics were found when compared to non-certified clinics. They were found to report greater levels of satisfaction. So they did track that. It's gotten trickier sometimes. There used to be this measure called CAPS that was used by a lot of the state used to include it in their measurement system, and so they used to collect data on it, which allowed us to really look at patient satisfaction much more extensively. However, there was a cost to CAPS, and because of that, they eventually discontinued requiring it because of some complaints around the cost of that measure. And thus, at the state level, at least from a comprehensive sense, we lost some of our ability to see into patient satisfaction. But I can speak to the evaluations of our program again that spoke to that enhanced level of satisfaction. Also, some of the recent research that we did through this MNCares Minnesota care coordination study we did with health partners through a PCORI grant. They looked at that too and looked at satisfaction and found with care coordination you were getting higher levels of satisfaction on the parts of patients as well, because I think they felt their voices were more heard. They felt their care was being more readily addressed. And if you have a patient-centered model where the patient's being told you're in charge, I think generally speaking, that's just going to lead usually to people being more satisfied than if they're kind of put in a position where they're being sort of told what to do. So that's kind of, and I saw also Stephanie threw into the chat too that in her
Yeah.
experience where she worked, clinics were very appreciative. Yeah, thanks Stephanie of the services.
Yeah.
So
yeah, that's great. That's great because I always think that makes such a difference because we assume they, when the objective things are good, that they are realizing that it's been a beneficial thing, but they don't always, they don't connect it.
It's true. It's true sometimes, yeah, and it can be hard to track, absolutely. And to really know, you don't want to look at like Yelp reviews or something like that to sort of find out how people thought about their clinic, their experiences in healthcare. So, yeah, but at least what I've heard is good news in terms of the kind of model we use, and it'd be
Well,
interesting to
thank
see
you.
more of general statewide survey. Yeah, thank you.
Thank you.
I don't know who other hand for Dr. Julia.
Yeah.
Sure. Good evening, everyone. Thank you, David. Can everybody hear me?
Yes.
Yes.
Sure. Thank you. Great, excellent presentation. Your presentation has just expanded, some of my conceptions or ideas I have about. I'm new to Minnesota, Minnesota healthcare system. I'm from DC. I always, when I discuss or when I go home, I always say Minnesota has a great, healthcare system. Like Rachel said, we don't compare, state to state. But I know of, a family member here that is receiving chemo and they're doing home infusion. They come to the house and hook her up the chemo. And I mean, it's over a year now and it's going, great. When I say great, excellently. But I have a family member who is an oncologist at John Hopkins in Maryland, Baltimore. So when we talk and I was sharing, I'm like, this is what I'm noticing in Minnesota. I I haven't practiced in a hospital setting since I came to Minnesota. I've been in academia. But, I worked for a very long time in the hospital setting in DC, Maryland. I didn't hear that, you can receive your chemo at home. I'm not an oncology nurse though. So I was discussing with him and I'm like, this is what I'm seeing. I know somebody receiving chemo, they do home infusion, in Minnesota. And he was like, how? I said, but how do you all do it? Because he's clientele pediatric oncologist. And he said, oh no, whenever they are, scheduled for their chemo, they have to come inside, come into the hospital setting. It's one day, whatever, 3 hours, 6 hours, they have to come in to receive the chemo. And I'm like, I said, DC, Maryland, we are behind. We need to talk to Minnesota and find out, what is going on. So I'm really impressed. And thank you for clarifying your name, because when I saw the name, I'm like, and you started talking, I said, oh, okay. I'm glad he's, clarifying that. Thank you so much. I'm really appreciative of the presentation. Has expanded, the discussion I've been having for the last 1 year.
Oh, thank you very much. Appreciate it. Thank you. Alex.
Hi, David. So I am currently a healthcare home nurse for one of our primary care clinics. And my biggest question is, how does healthcare home, and I mean, I'm assuming you've heard the term CCM, chronic care management. Okay.
Sure.
How do they go hand in hand? How do they differ? Because we're healthcare home, but we are also CCM.
So maybe I didn't know. When I'm thinking of chronic care management, like the
Correct.
codes. But yeah, okay. So you're saying you're billing using CCM codes for some of your care management services. I mean,
Yes.
A lot of those codes I think are. I mean, and correct me if I'm wrong, because this maybe I could be wrong about this, but I thought a lot of the CCM codes were Medicare codes that we use with Medicare patients. So typically,
and that sounds correct. Okay.
And that's a very common, I would say, use of CCM codes with care coordination, chronic disease management. That's a very common billing mechanism, absolutely, for Medicare patients. And I know a lot of healthcare home certified clinics that use that. I mean, the healthcare home specific payment is more Medicaid focused usually, unless you have a contract with a provider. I'm with a insurer. I'm sorry, like a commercial insurer. But yeah, CCM codes, we advise folks to use them always with Medicare patients. If you know how to get your 20 minutes in or whatever that minimum requirement is, it's a very, and some folks have it down to a real science. I mean, in terms of being able to bill that way. So yeah, makes sense.
Okay.
Did I answer your question? I just want to make sure I'm not.
Yeah, nope, that was perfect. Thank you.
Perfect. Thank you. Christy.
I think Stephanie, you were before me.
Was Stephanie first?
Yeah, go for it.
I was just going to make a quick comment, David. So regarding the last comment that was made with Alex, CCM billing is really a major sustainability strategy. So it costs a lot of money for clinics to be able to afford to have nurses and others providing services that are part of the healthcare home certification. So being able to bill CCM codes and some of the other codes too, PCM codes and COCM codes and TCM codes, there's a whole suite of care management codes that can be billed. And those codes, while they are somewhat bureaucratic in terms of being able to kind of jump through all the hoops that you need to jump through to be able to bill for those codes, they are a huge factor in sustainability for the healthcare home, because they pay for part of the expenses that clinic acquires by having the additional personnel.
Mm-hmm. No, thanks, Debbie. That's absolutely 100%. And as I agree with you on that point. And that's why we definitely recommend, when you can put it together, to use CCM codes. And you're right, a lot of these other COCM codes and other codes that are out there, you're right, there's a whole suite of them. And we're trying to work to make folks more aware of those and some of those strategies. That's been part of our sustainability efforts too. But you're right, because it is expensive. I mean, absolutely, to have the staff in place. So thank you very much for highlighting that.
Yeah, and I appreciate too. That was a big learning opportunity for me, because it's very expensive to staff. the care coordinators and the RNs. And as we know, we're getting our funding cut by Medicare. It feels like all the time. So, okay.
Yeah.
Thank you.
I hear you. Christy.
All right. So I was very excited for this presentation. I got to be part of healthcare homes in the CMS pilot days and worked for about 10 years in helping develop one of the local systems. And then we integrated embedded care coordination into 24 primary care clinics. What I know now about that is that none of that is happening anymore. So my question is, there's been great things. Those a lot of those things have developed over time. We've been able to prove the cost of care coordination is worth it. But we had none of that stuff back in the day. We were getting some like $1 million grants here and there from Blue and other things like that to be able to do care coordination. But all of that billing and stuff in the early days was really rough. And so there's been lots of great learnings, and the ACO, all of that stuff has gone to some interesting places. What my question is how have you seen some of the kind of rolling back of some of these efforts with some of the major systems and maybe even payers, because especially in the care coordination area, so I'm just wondering, like, if there's been a change in I know that was brought up before, patient satisfaction or provider satisfaction. One of the things that was important to me about the integrity of the role was because in many of the healthcare organizations locally and in the metro area, care coordination was a second duty of like a nurse or whoever. So it was like you were a triage nurse primarily, or you did the flu shots or whatever. And when we developed it in our system, it was really important to have that role be like sort of an autonomous role. But then we also became, like many of us became diabetes educators and things, and we were doing the chronic disease management with heart failure and all that. But that seemed much more adequate, or much more to that role. I don't, as part of care coordination rather than maybe triage, even though we might triage the individual patients, if that makes sense. So all of this to say, how are we doing in the care coordination landscape and really meeting those needs that healthcare home was intended to meet in the current landscape?
Yeah, I mean, it's a complex question. I think when it comes to care coordination itself, I think it's I'll say this, I think it's very encouraging. I think in the time since healthcare homes started, you would see a lot more organizations say, now we do this as just part of our standard practice, even regardless of whether we were certified as not or not. This is now kind of part of our organizational DNA. So in that sense, that's great. I mean, that's really what we're shooting for, is to try to really help affect sort of practice transformation that has a more of a long-term impact. The caveat I would put in there, though, is that while we hear that, you do worry a little bit, because one thing we see sometimes is organizations will change leadership and all of a sudden they'll just drop what they're doing, and kind of, it might be the DNA until all of a sudden you have a new CEO or you have a new C-suite team or whoever, and all of a sudden they toss out whatever was there and they go for something else. That institutional memory piece can be very tricky, and it's something that we're really trying to work on as a program to strengthen the ways that we can onboard people essentially when they come into their roles and pass information along so that we don't end up with these gaps. So I would say that while I'm overall encouraged by where we're going, I worry sometimes about the rapid fire turnover in personnel leading to the collapse of some of these practices in some cases. I know of some clinics that have really abandoned some of these things. And look, I mean, they're also facing unprecedented financial challenges. So, I mean, I don't want to sound judgmental about it. I don't know what's going on in their inner meetings about their bottom line. And I mean, we see all kinds of service lines are being cut. I mean, I've seen an unnamed major system that dropped their entire behavioral health division. I mean, they let go every therapist and person they had on staff. I mean, again, so that's part of it, is that they're running into these financial challenges. But I do think there's also this piece around turnover, and I think it's so intense sometimes in the clinic and as well in some cases the hospital world, that there is the real danger there. And so again, I think we need to build these systems where we can find ways to make sure that new leadership is apprised of why this is something valuable, and why it's been at a given organization for 10 years or 15 years or whatever it might be. So yeah,
I'm
so
so
hopefully,
happy that's like in our language now, at least,
yeah,
that care
me
coordination
too.
is, and the understanding that we see people for a very small fraction of time, whether it is in primary care or acute care. Thank you, Stephanie, for that. And also, David, I used to love the healthcare home learning days and the conferences. You guys are amazing. I
Yeah,
remember that from back in
thank
the
you.
day, and I subscribe to the newsletter, of course, because
Oh,
I'm there
fantastic.
also. But
Good
I
to hear.
didn't know that I could come if I wasn't part of that. So
Anyone
now I
can
know I
anyone
can
can
come,
come.
and so
You
I'm
can.
very happy about
Absolutely.
this. All
Yep.
right.
Yep.
Thank you.
Thank you so much, Chrissy. Appreciate it.
Take care.
Yeah, you too. I know.
So I have a comment.
Yeah.
I was really intrigued by your asking clinics what they're proud of. I worked on a project with my partner several years ago with a school in New Mexico that got a turnaround grant to try to not be a failing school anymore, an elementary school. And they had all these things they had to do to get the grant and all these things they had to measure to keep the grant. And they were successful. And nobody asked the teachers what worked. And so
Yeah.
we were hired by a family foundation to go in and talk to the teachers. And of all like the 25 things that they had to do, there were three key things that the teachers said made them feel like professionals for the first time in their careers. And so you have this like rich data of like what are they proud of and how can that be shared to kind of elevate what they're doing that's good instead of like all of the, filling out all the boxes.
Yeah. Absolutely. I 100% agree with you. And that's, we try to showcase stories in our newsletter and elevate stories about what folks are doing. Because I mean, as you just said, there are these incredible successes out there and amazing programs that people are doing, and innovations that different folks are coming up with that could, I think, really also be replicated in some cases, right? But they're just not necessarily being brought to the attention of anyone outside of maybe the immediate, area or
Right.
whatever. So I mean, one vehicle is using our newsletter and our conference and stuff to try to amplify those stories and get them out there. The peer-to-peer learning network I talked about is another way we're really hoping to, at least within the healthcare community, try to get some of these successes out there and try to get folks to talk to each other, so that someone in Bemidji can chat with somebody in Bloomington or whatever who might actually have more in common than they thought in terms of their patient population, and might discover that they're doing something that could be replicated, despite differences in geography, for instance. So, I mean, that's another way we're really hoping to do that. And definitely, as you said, it's part of our recertification process is having folks showcase what they've done. And those are neat things to attend because some of the organizations show up with their teams and they bring patients and they really talk about the work they're doing. And it's always pretty amazing. I mean, to hear about the number of things, and the amount of work that folks are doing as well. I mean, one person doing 5 jobs, sometimes it sounds like. I'm going to get these things done. So it's pretty incredible. I do see in the chat, you have some stuff about mandating healthcare home education and talking about it with nursing students. I mean, that's something, yeah, Alex and Stephanie, we've been trying to work with more healthcare schools. We've been doing some presentations at some universities and trying to now get maybe into medical schools and nursing schools. It's a very early days on that front, but we would love to talk more about how we could integrate some of the education around care coordination and care teams and some of these other practices and get them really into the sort of fabric of the education for our healthcare providers and healthcare staff. It seems like it's gotten better. I mean, there's more conversations about some of these things, but clearly there could be, we could do more, absolutely. And so would love to talk to some nursing professors and others and try to find ways that we could get this into curricula. I know some who do, but it's far from universal.
So David, it's Alex. I was actually thinking more like as part of the healthcare home requirement, right?
Oh, I
anyone
see.
who's
Okay.
anyone who's hired onto a role of a healthcare home clinic should have to go through a mandatory training to really understand the purpose of this program, because
That's a neat idea. Yeah.
I understand it, but I have learned so much in this presentation, and I've been doing this for 4 years, that nobody has come and explained to me. And it's like, I have a whole new picture, and I should have started with that picture.
No, that's a great point. There's some clinics that do that just of their own free will. They require everybody to take this e-learning course we have that introduces the whole healthcare home program, but that's a minority of organizations. That's a neat idea, Alex. I'm going to take that back to my team and at least talk about how we could work on that. Because yeah, you have a lot of folks I talk to who are in healthcare home certified clinics. They've heard that they're certified, but they really don't maybe even know much about it. I mean, because it's not specifically their role to coordinate care or to work with those teams, they just may not. And certainly the bigger the organization, the more likely that is, because you end up with just a very large and complex organizations and folks doing different stuff. But it'd be fantastic, just to have that sort of awareness raising piece, because I think it matters.
100%. It's the whole purpose. It's the whole foundation of the program. And if people don't understand what they're doing, why they're doing it, or who they're doing it for, what the purpose is, I mean, that's where we're going to lose and have that turnover.
Yeah, I think that's a really good point. Yeah, that's great. Thank you. Really, really interesting idea. I gotta think about that. I have something new to bring back to the team.
Cool. Anyone else have questions, comments? I'm seeing in the chat that you're a hit, Dave.
Oh, thank you. Yeah, I'm really glad. I'm so glad I was invited to come and talk to everybody here. This is great. I mean, I love talking about healthcare homes. I love meeting people as well, and I have only so many opportunities to do professional development or get out and meet people. So this has been a great experience. And I mean, thanks to everybody here. Thank you, Kathy, again. Thank you, Stephanie, for again making the connection. Stephanie's an awesome supporter of healthcare homes and member of our advisory committee and a rock star. So I'll call her out there specifically. But yeah, thanks so much and much appreciated.
Great. Thank you. And thank you everyone for coming on a pretty nice May evening. So it's great. Thank you. Now have a great rest of your evening.
Thank you.
Take care, everybody.
Have a great night.